All right. Well, it looks like we're a minute after the hour, so we want to go ahead and get going. And I want to thank everyone for joining us today, whether it's morning or afternoon. Welcome. My name is Carrie Frank, and I'm the Vice President of Communication and Marketing here at CIVHC, Center for Improving Value in Healthcare. And we are excited today to be discussing how we are working in Colorado to connect rural providers to data to improve the health of their communities. We have several fantastic presenters with us. I have Andy Waster, sorry, Andy, from CCMCN, John Kennedy from the Office of eHealth Innovation, and James Stevenson from the Colorado Rural Health Center. I will introduce them a little bit more here in a minute, but we're very excited to have the three of them join us today to talk about this important topic. Just quick agenda. We're going to run through a tiny bit about CIVHC, just so you know who we are. We're going to talk about the Rural Connectivity Program, the Community Analytics Platform, and the future of rural connectivity. And then we'll have plenty of time for Q&A. And speaking of Q&A, just some housekeeping items. All lines are muted today, so we do ask that you ask questions in the chat box. You can either direct them directly to the hosts and panelists, or you can put the questions out to the entire audience, up to you. You don't have to wait until the end, but we will have a formal Q&A at the end. But if things pop up throughout the presentation, please feel free to chat in the chat box. We may save them for the end, or we may take them right then and there. So we'll kind of use our judgment on that. We are recording this webinar, and that will be posted in addition to all of the slides on our website at the event resources page at civhc.org. So just a little bit of background in case you're joining CIVHC's webinars for the first time. We are a nonprofit organization that equips partners and communities in Colorado and across the nation with resources, services, and unbiased data needed to improve health and healthcare. And if we achieve our mission, our vision is that everyone will have the opportunity to be healthy and has access to equitable, affordable, high-quality healthcare. As I mentioned, we're a nonprofit, we're independent and objective, and we really are focused on the services that we provide. And who do we serve? We serve a wide array of what we call change agents, which are individuals, communities, and organizations that are working to lower costs, improve care, and make Colorado healthier. So you can see consumers are there in the middle. Everything we do is focused on making Coloradans' lives better, but we partner with clinicians, hospitals, employers, nonprofits, state agencies, researchers, health plans, many of which you're going to hear from today. So the way that we serve in terms of the data that we provide, the majority of the data that we work with is through the Colorado All-Payer Claims database. We provide public information that helps identify opportunities for improvement. There are interactive reports and publications on our website, a plethora of topics that you can go use and for however you see fit to make improvements in healthcare in your organization. And then we also offer non-public co-APCD data, which is some of the data that you'll see today. We have worked with the Colorado Community Managed Care Network to give them data sets that then they're using for the programs that you're going to hear about. We also provide research and evaluation services and work in program focus areas of advanced care planning and palliative care, and do a lot of community engagement work. So today I am honored to be joined by John Kennedy with the Colorado Office of eHealth Innovation. He's a senior project manager for rural analytics. James Stevenson is with the Colorado Rural Health Center. He's the associate director of health information. And Andy Waster from Colorado Community Managed Care Network. We call that CCMCN. It's a little easier. Population Health Analytics Director. So I am going to turn it over to our presenters.
Thanks, Carrie. I'm just going to go ahead and just give a quick background of the program and where we're at. Originally initiated as a COVID-19 data surveillance initiative led by Colorado Community Managed Care Network, CCMCN, CRHC, HCPUF, and OHI, collaborated to enable the 32 critical access hospitals and 52 rural health clinics statewide to report COVID-19 related data. This comprehensive reporting facilitated a better understanding of statewide care cases, hotspots, and resource allocations. Subsequently, each facility accessed an interactive COVID-19 surveillance dashboard, empowering them to make well-informed decisions regarding COVID-19 patients. Concurrently, CRHC partnered with HICPUF and OHI to devise a solution providing free or significantly reduced cost connectivity to the HIEs in Colorado for rural hospitals and clinics, ensuring universal connectivity to Contexture and QHN, particularly for rural health facilities, which became a priority by the state, with technical support being essential for these connections. And since January 1 of 2023, Contexture has offered complementary connections to the HIE, resulting in 100% participation from all 84 facilities utilizing Contexture and QHN. What originated as COVID-19 data surveillance has evolved into developing more tailored dashboards, including those focused on cancer, diabetes, outmigration, ADT, cardiovascular, childhood immunization, and others. Over the past year, efforts have been directed towards engaging independent facilities, with CRHE providing technical assistance for the program. This assistance encompasses direct collaboration with EMR systems, HIEs, and supporting facilities with dashboard training, workflow optimization, and ensuring data quality and quality improvement activities. Furthermore, the program offers substantial financial assistance via the rural sustainability payment. Eligible rural clinics will receive yearly appropriations of $20,000, while critical access hospitals will receive $100,000. Our introductory round of funding has concluded, and our focus now shifts to assisting independent facilities in obtaining similar access. So in summary, the program not only grants access to vital healthcare data and promotes collaboration among organizations, but also commits to providing financial support, showcasing a commitment to sustainability and improvement of healthcare in rural communities. With that, I will go ahead and pass it over to John Kennedy.
Perfect. Hi, my name is John Kennedy, not a joke. I did take a look at the participants, the attendees here, and I do see a lot of people that I'm familiar with. So shout out to all of the people who do know and who I work with regularly. There's some people on the call that are a part of this, and success to this has been to that. I see Contexture on the call, I see CCMCN on the call, and I see Rick Kurtzinger with QHN on the call. So just a shout out and thanks to everybody there. Kind of as you take a look at this slide, I'm kind of going into some details of the background. In rural, there is a higher burden of poverty. There's 20% of rural children live in poverty compared with 11% of urban children. 12% of rural adults lack basic literacy skills. There's lower access to health care. 45% of rural Coloradans have public health coverage compared with 35% of urban Coloradans. And then 54% of rural counties completely lack OBGYN services. We refer to that as a maternity desert. You may hear that term a lot in your space. And then there's worse health outcomes. Nine of the 10 Colorado counties with the highest opioid death rates are rural, and rural teens are twice as likely to commit complete suicide as their urban peers. When we first got this kind of going and out the gate in 2020, OHI established that all 60 independent rural clinics and 49 of 84 rural safety net facilities were not connected to the HIE network and lacked technical workforce. So one of the successes we have here is that we are cruising right along. We've got mostly HIE connectivity. We've done a great job there. 100% of the safety net providers now have HIE connectivity, and a large portion of the independent rural clinics now have HIE connectivity. We're also working towards the community analytic platform, which is what we're talking about here. And we started with low participation, and we've gotten much higher participation rates. One of the things, and James touched on it, but it is something to celebrate, is the R7 sustainability payment. So that is, like he mentioned, $100,000 per critical access hospital and $20,000 per rural health center. And that it goes to those who are connected to the HIE and connected into the CAP and are participating in the rural analytics program. There is one little thing I'd like to note there for anyone on the call who are unfamiliar with this. If you are a provider, our emails will be in the end. Please reach out to James or myself and say, hey, am I getting this payment? I want this payment. What do I need to do? And we'll make sure we'll let you know. Either A, you just need to sign a participation agreement, or B, you're already set up and you probably got the payment. Not probably, you would have gotten the payment because the first one was issued in March. So just wanted to make sure I point that out to anybody on the call. And for me, I'll go ahead and pass it on. Thank you so much. Next slide.
Thanks, Gary. Thanks, John. Yeah, this is basically our participation, current participation for the CAP. As you can see, we've got 69% of rural health clinics that are contracted to participate in the rural connectivity program, or the CAP. 56 of those facilities have submitted demographic files. 31% are connected to or have completed the TP authorization, which is the 834 Medicaid attributed patients, and 58% of those RHCs have also completed this CIS agreement, which is all about immunization. For our cause, we've got 75% that are participating in the community analytics platform. 69% of those folks have uploaded demographic files. 28% have completed the TP authorization, and we've got 50% that have completed the CIS agreement. Next slide. Andy, go ahead and take it away.
All right. Thanks everybody for joining today, and thanks to our partners at CIVHC and both to OHI and the Colorado Rural Health Center for all of their support on the project. My name again is Andy Wooster. I'm the Population Health Analytics Director for the Colorado Community Managed Care Network, or CCMCN. CCMCN serves as the primary technical partner on the Rural Connectivity Project for the Community Analytics Platform. And you've heard that name a whole bunch of times already. We'll give you a view into what that is here in just a moment, but I want to first introduce you to who we are and how we got involved. So CCMCN, or the Colorado Community Managed Care Network, is a Colorado nonprofit. We were founded in 1994 and serve as the health center controlled network for Colorado's federally qualified health centers. That means we're governed by, and our board of directors is comprised of leadership of Colorado's federally qualified health centers. So they set the direction and vision for the organization and approve sort of our roadmap for the direction that we want to go as an organization overall. In terms of our mission and our approach, we really strive to provide community organizations with innovative solutions to improve costs of care, quality of care, patient experience, and ultimately, one of our aims is to minimize health disparities. We are federally and state supported. You can see that based on participation of OHI here on the call today, as well as HCPUF and a number of other state partners that we're very grateful for. And of course, as the Health Center Controlled Network, we're funded by HRSA to do that work. So appreciate all of the funding that we get from government entities, both locally and nationally. And then we define success as providing systems that help lift vulnerable populations out of poverty. And you can see up here in the top right corner of this graphic a number of the different outcomes that we work on. So maternal and child wellness, behavioral health, healthcare cost, patient experience, care coordination, chronic conditions, et cetera. So we really run the gamut of healthcare related content areas. Next slide, please. In terms of the data infrastructure that we have for the Rural Connectivity Data Network, there are a number of different ways that an organization, one of our certified rural health clinics or critical access hospital, or even the independent providers that John and James both mentioned, can participate in the project. And so starting from kind of the top left here and moving clockwise around this infographic, we've got patient demographics. So that's provider roster files that they upload to us. Once we have that file, we can take that file and match it up against any of these data sources that we have within our sphere. and use that to gather information and create reports on the members of those organizations. Participation agreements are another one that you'll see here, and this basically spells out our ability to gather Colorado APCD data on the behalf of the provider who is participating in the project. TP authorization, as James pointed out, that's our 834 enrollment files. So we get daily and monthly files from HCPF on Medicaid enrollment lists for the providers who are participating in the project. And it just helps us to round out that cohort that we're searching for data points on. And then down here in the dark blue, on the lower right, the CIS agreement, that is an agreement that is specifically signed for partners in the rural providers in the Rural Connectivity Project for us to gain access to Colorado Immunization Information System immunization records on their behalf. So we send them our cohort of participating members or participating organization members, and they send back immunization records that we could use to build reports on and provide them with critical intelligence for healthcare operations. And then if we just go around the circle here clockwise again, looking at the data sources, so the APCD data is represented by this CIVHC block. HCPF block represents the Medicaid enrollment data. CDPHE block represents both the Colorado Immunization Information System, and we match with their vital statistics program to get death certificate data on a weekly basis. We get real-time ADT, admit, discharge, and transfer feeds from Colorado's health information exchanges, who, as multiple people have noted, are participating here on the call today. So that's Contexture and QHN. We also get lab feeds from both Contexture and QHN to help us capture some of those laboratory test results for our members. We have a feed that comes in from LabCorp as well to help round out our laboratory feeds. And then the provider feeds, which really just represent those demographic files and help us to capture a broader cohort of members that we can provide more intelligence to the organizations on. For future data sources, things that we're looking to capture going forward, SDOH data. So we have probably two different categories of SDOH data that we're interested in. One is self-reported member level data, and then also ecological or geographic data on SDOH. So what is where a person lives, their home zip code or their census tract tell us about what their health conditions might look like. And so how can we tie that into the outcomes that we're seeing for our populations? We also would like to access clinical data. We have EHR connectors, and so we're hoping to venture eventually into the space of beginning to capture clinical data for the rural organizations who are participating in the project. And in the not too distant future, we'll be launching a new claims cost analytics and utilization tool that we're happy to talk more about, and that will provide some robust and validated reporting metrics for organizations who are participating in the project. So next slide, please. So a little bit more about the community analytics platform itself. We're calling it the CAP for short. It is a new reporting platform. We've had a version of this previously, but it was hosted in another environment that was outside of our control to a degree. But in December of 2023, we launched a new version built entirely on CCMCN's Honeycomb data network that captures data from all of those sources you saw previously described. We take that data and we produce reports based on that we think will be useful to the providers who are participating in the project, and we gather their feedback to update and modify those reports. So we're really excited about this new platform. We've gotten great feedback on it to this point, and we're looking forward to the future of it. Importantly, CCMCN is high trust certified. The CAP is multi-factor authentication enabled, and we have multiple levels of permissioning that we can implement, including row-level security. So we have plenty of opportunities to make sure that the data is locked down, and when a user logs in, they're seeing data only for the organizations that they're provisioned to see data for, which is great because, of course, we're dealing with a lot of really sensitive data. And then just as a kind of quality of life component, users can only see menus and reports, et cetera, that should be provisioned to them. So they're not seeing, for instance, when I log in, I see 20 different menu options, but not everybody has access to all of those, which just makes it look a little neater and cleaner from their perspective. So next slide, please. So this is just a snapshot that I pulled from our community analytics platform, and you can kind of see what the layout looks like. So when somebody logs in from one of our rural clinics or one of our critical access hospitals, they'll see a list of recent reports that they could access here. Those are things that they would have accessed when they logged in the last time. Down below, if you look a little bit lower on the slide, you can see a directory where they can search for specific reports. But really, this is filtered to only the reports that the Colorado Rural Health Center has access to here on the top menu. And so you can see we've got our little CAP logo that we're hoping to sort of push along with the abbreviated name of the community analytics platform, and then all of the categories of reporting. And I've just hovered over COVID in the snapshot to give you a sense of what a provider might see when they're coming in to access one of these reports. So again, pretty neat and clean. We've got a staff member who has some background in visual design and did a great job of laying this out, not making it too busy, and really kind of making it accessible and approachable for the providers. Next slide, please. In terms of the reports that we have available, James, I know, mentioned several of these reports when he was kind of kicking off the presentation here today, but just to give you a little bit more background on what's available to the rural organizations as of this moment, we have our ADT summary report that's going to look at admit, discharge, and transfer notices for the members of their population over the last 90 days. So if they want to go in and see who was admitted to the hospital this weekend or who had an ED visit over the last 24 hours, they can go into that report. They can see it. They can see a breakdown of the diagnoses. They can see the sending facilities, and other various demographic characteristics of the member, but they can also go in there and they can get a patient list that they could actually action from to do some outreach and get those members engaged in care, keep them out of the ED if they can avoid those trips. The next one is the Medicaid Attribution Report. This is a long-standing report for us. It looks at the 834 enrollment data and looks at Medicaid membership for the organizations. And it gives historical trends, current enrollment. It looks at how long a member has been with a specific PCMP. And it also has a new module that we added within the last year that focuses specifically on the public health emergency unwind and the impacts to the Medicaid population of that. So you may know that when the public health emergency ended, the continuous enrollment benefit also ended, which had big or substantial impacts for the Medicaid population. And what we can actually see in that reporting is, a lot of our organizations seeing 30% or more decreases from this time last year in their total Medicaid enrollment and their roster size. So we've got a number of providers who are logging into that report on a monthly basis when it's updated to see what's changed over the course of the last month and get a sense of, especially if they're getting a PMPM payment, what that's going to look like and predict those financial outcomes for their organization. Next is the outmigration overview. And this report really looks at who's being seen at their home facility or the facility that they're attributed to or the parent organization they're attributed to, and what services or what members are being seen elsewhere. So are they leaving Yuma, Colorado to come to Denver to get primary care? And if so, why and how do we get them back into primary care? So there are a lot of metrics in there. I won't go into it in too much detail here, but we're going to see a snippet of what that report looks like, or one of the components of that report in a minute. The shared populations report is a report that I kind of call a outmigration light. It doesn't go into all of the sort of encounter level detail that the outmigration report does, but it tells you, hey, these are the number of patients that have also been seen at Lincoln County Hospital or one of our primary care practices in the Eastern Plains who've also been seen on the Western Slope for primary care or something like that. So just kind of gives a little bit of a lighter view into where our members are shared. And a lot of times that makes perfect sense and people are already aware of it, but it's nice to kind of have those ideas validated. We've got the childhood immunizations report. So this is based on a Colorado immunization information system data. It looks at immunizations and on-schedule members and off-schedule members according to the AAP Red Book immunization schedule. So it's a fairly complex report. There's a lot of logic that went into that report, but you can get an overall sense of your population health, as well as, if you're a provider, an overall sense of your population health, as well as individual level information about specific immunizations that a member has. We've got a suite of chronic disease reports over here on the right, so cancer and diabetes. I won't go into those in too much detail here because I'm going to show you a couple of images of those, what those look like, and then a suite of COVID-19 reports, which I know James mentioned previously and is kind of the impetus for the inception of this project. So there's a lot of available information out there, including the vaccination tracker, which, there's less interest in COVID-19 reporting these days, but there's still reports that we have available, and maybe we'll sunset them at some point in the future, but for now, they're still stimulating enough interest to keep them going. Next slide, please. All right, so uses of APCD data in rural connectivities. So how are we actually using Civic APCD data in the work that we're doing on the Rural Connectivity Project? So from my perspective, for the community analytics platform, there are really two primary ways that we're using it. So creating population level views for providers to understand population characteristics and well-being, identify common diagnoses, procedures, and cost drivers, determine patterns of utilization and shared membership. And then I think ultimately, one of the goals for the population level views is not so much for workflows, but it's for executive leadership within these organizations to understand to a degree what's happening within their organizations, provided all of the caveats that we'll present the data with. But they can make decisions about, are there business lines that we need to think about opening, or are there business lines that just no longer make sense for us? And so hopefully, ultimately, as we start to get more engagement and more feedback, specifically on something like the outmigration report, we'll start to see more conversation within organizations that will be informed by the data that we're getting from the APCD, and can help to drive that decision making, sort of in the spirit of the theme of our webinar series here today. And then creating identifiable patient record views. And so this is a useful use case for APCD data in this reporting for follow-up and engagement and care. You've heard that as a consistent theme. You saw it on one of our earliest slides around care coordination. So we do provide lists for folks for follow-up and specific individual member information, and then understanding a patient's journey through the healthcare system and developing a more longitudinal view of patient services. So among the reports that we are using APCD data in, those are the use cases that I see. And I will caveat our use of APCD data with, we have very few use cases where APCD data alone is supporting a report in its entirety. Okay, next slide, please. All right, so what do these actually look like in practice? And I'm sorry for the a little bit of the lost resolution in the screenshots of these views. It's a screenshot of a screenshot so that I could blur out some of the more sensitive information. But this is a view of what is one of our chronic disease suite reports. So this is what we call our diabetes screening and diagnoses report. And so within this report, there are a number of different views that a member could see. You can see those indicated by the 4 blocks at the top of the view. We've got a patient population overview, a patient list view, and then some ADT summary or some ADT views within the report. And that's a pretty common thing that we do. So just looking at this in a little bit more detail, for our rural membership, we could see based on the data sources that we have access to, we've been able to identify roughly about 25,000 members with a diagnosis of diabetes, and we present some metrics on that population. So you can see an overall average A1C, an average A1C, most recent A1C for members diagnosed with diabetes, pre-diabetes. Over here to the right, you can see a number of filters so that a user could get down to any specific subsegment of the population they were interested in. And then down here, one of our caveats, this is a great example of one of our caveats here. This long-term or the diagnosis date graph, you can see the spike around 2022 and 2023. Obviously, we don't have a ton more people who are being diagnosed with diabetes in 2022 and 2023. That's a function of artifact based on when we're getting new data feeds and data feed updates. So as we get a whole slew of new incoming data, the earliest diagnosis date, if we don't get historical data for those members, is going to be in those times when we get those new data feeds. So we get some artifact that we have to explain when we're talking to organizations. We break out all of our metrics down here at the bottom according to various demographic categories. We give the users the ability to see this in virtually every report that we create. And all of those are filterable. So if you want to look at any subset, you can easily click on that bar, filter down to that population. Over here on the right, you can see some information on members ever diagnosed with common diabetes complications. You can see some information on recommended screenings within the last 18 months. We sort of extended that beyond a year just because we know we have a lag in getting the APCD data updated. And so we extended that time frame out just a little bit, and then some common comorbidities. So this is pretty characteristic of the kind of report we would develop for this project. Within this population list view, you could see individual information on diagnosis dates, screening dates, comorbidities or complication diagnosis dates, and when their most recent A1C was from the sources we have available. The ADT summary view is specific to the diabetes population, or the population of folks here with either a high A1C, who we couldn't identify a diagnosis date for, or a member diagnosed with diabetes. And it could show you, hey, this number of members were seen in the ED over the weekend. We should do something to follow up and make sure, do we need to do some diabetes education, or is there something that we can do to keep these folks out of the ED? So again, that care management piece sort of circling back into the conversation here. Next slide, please. So the next slide is, or the next report that we have available is our cancer screenings and diagnoses report. And this one actually has a couple more tabs up here at the top. So you can see over here, we've got ADTs again. So we're always sort of presenting that in combination with these chronic disease reports. But we've also got information here. The main view is of screenings. The second view is of diagnoses, treatment, and mortality. And so here for the population, you can see a number of metrics related to screening. So total screen count, the number of members who are screened, and then among those who are eligible for screening, according to these categories over here, you can kind of see how many screens there were among eligible members, how many eligible members were screened, and how many total eligible members there were. So this would be like a denominator metric for whether somebody is up to date. And you can see this timeline here, it's relatively long, and you can see these upticks here toward the end of the timeline. That's good news, because that means most of the screenings that we're identifying for these members are happening, the most recent screenings are happening within recent years, right? If the most recent screening we were identifying for everybody for prostate cancer or breast cancer was happening in 2014, that would be bad news in terms of clinical care, right? So, so that's good news. Looks a little funny, but it makes sense in terms of the data. Up-to-date screenings, you can see kind of some breakdowns over here and some general information about who's included. You can see we've got breast, cervical, colorectal cancer, and prostate cancer included in the screening section of the report. We also have uterine, skin, and lung and bronchus cancer included in the diagnoses and treatment section. But either because we don't have access to the right kinds of data, or there are no generally agreed upon screening protocols for the types of cancer, they aren't included here. All right, next slide, please. This view of the cancer report reflects diagnoses, treatment, and mortality. And so you can kind of see a breakdown of the earliest identified diagnosis date for specific types of cancers. You can see the unique members diagnosed. You can see the total cancers diagnosed. So if a member has records for more than one type of cancer, you can find that here. And then we've also got a section for deaths where there was a mention of cancer among the causes on the death certificate. That would come from the CDPHE vital statistics data. So you can kind of see the timeline here. There are a number of filters that we always provide with any of these. We've got basic demographic breakdowns here. So you could filter that by cancer category. You could filter it by treatment category. You could filter it by death and kind of see what that breakdown looks like. Over here on the far right, we've got some interventions. So we've got procedure codes, that we identified for specific cancer types and surgical interventions that were done for those specific cancer types, and then some other treatment information down below. So the percent of the population where we were able to identify chemo or radiation. And then kind of in the middle right of the report, you can see a breakdown here of cases versus the number of members where that cause of death was mentioned on the death certificate. And so this is sort of mimicking a little bit of a mortality rate, if you will. I would say a mortality rate light, because we know there are gaps in identifying cases as well as gaps in identifying deaths due to our member matching process, specifically for the death data. But overall, generally trying to present as much useful information as we can. And then, of course, the ADT summary component of this would look at anybody who was diagnosed and give you a list of members within the last 90 days and ED visits or inpatient stays for that member. So hopefully providing, again, more information in the care coordination sort of space. All right, next slide, please. Not to forget our origins, I wanted to include a COVID-19 report. This is not one of the original reports. The original reports really started around syndromic surveillance and symptomatic visits to the ED. And of course, as they rolled out codes and people started using those codes, we were able to change the definitions to what we were capturing here a little bit. This specific section of this report, you can see there are multiple sections focusing on the combination of all of our data sources, using some of this is an EHR feed that we have with our FQHCs, which isn't applicable to our rural population. Then we've got a civic data section for the APCD data, and then we've got our HIE section, which would contain the labs and diagnoses from Contexture and QHN, and then a LabCorp section as well. But just looking at this, you can kind of see the trend here in diagnoses that were identified mirrors some of the trends that we were seeing in Colorado around spikes and valleys in COVID-19 diagnoses. You can see diagnosis codes, various demographic characteristics for the members of the population. And then we've also included a number of different chronic conditions that members were diagnosed with. All of this, of course, filterable to the rest of the report. So if you wanted to see the number with asthma and their diagnoses, you could easily do that. So just trying to present some of those high-risk comorbidities or chronic conditions that we know make somebody more susceptible to COVID-19. And again, as I said previously, COVID-19, not such a big interest of our end users anymore, but definitely some great work that we did during the pandemic and obviously led us down this path toward a broader approach to rural connectivity. Next slide, please. And then the last just quick view of a report that I'll show you is a view from our outmigration report. And this view is the second view in the report, which is called our outmigration population clinic analysis. And what this does is it really looks only at folks who were outmigrated. And outmigration is kind of a funny description, but essentially the way that we're thinking about it is somebody who had an encounter at a facility that was not their attributed parent org. So we're looking across hospital or healthcare systems to consider those as one group. And if they venture outside of that to another location, then we consider that outmigrated. So there are 150,000 caveats that I could provide about this specific view of the report. What you can see up here at the top is 2 rows of various different kinds of filters. We allow users to set the definition for outmigration. So as it is at default, one claim at a facility that's not affiliated with the attributed parent org or the parent org that we know that member to be associated with puts that person in the outmigrated claim category or the outmigration group. And so providers sometimes have questions about this until we explain to them, hey, here's all the different ways you can do this. So We've mocked up a primary or specialty filter. We're constantly trying to get feedback and improve the accuracy of that primary or specialty filter. We allow people, so if you look down here for this population at the rendering clinic, so who's rendering the services, you can see the #1 service is rendered to LabCorp. That probably isn't an out-migrated visit. That's probably an order made by that parent clinic. And so if you come over here to the rendering clinic list, you could filter out LabCorp, or you could filter out Mountain Radiology or Western Colorado Radiology. We know those are associated with encounters often within the facility. And so we really give people the ability to drill down. We've also estimated distance from the home site to the attributed clinic and to the rendering clinic. And this is zip code to zip code centroid as the crow flies, which we know specifically in our mountain valleys doesn't work very well. You could be 5 miles from your home site, but have to drive 2 hours to get there. So again, some of these metrics have to be taken with a grain of salt, but I think we're providing value and providing a lot more detail to the organizations and a lot more information to the organizations than they were getting before the inception of the project. And just because I like this question, I will say to the person who asked what the BI tool was, it's Tableau. All right, next slide, please. All right, so what does the future of rural connectivity at CCMCN specifically and for the community analytics platform look like? So James and I think John both talked about this, but over the course of the last several years, we've really been heavily focused on getting those rural health clinics, the certified rural health clinics and critical access hospitals onboarded to the project. And now that we've got a number of them onboarded, and we're not giving up on the ones who are not onboarded, we're starting to move into the space of non-certified and independent rural providers. So who are these folks? These are the folks who don't meet the criteria for certification. So maybe they have too many beds, or maybe they're too close to an urban center, right? But in most cases for these organizations, or in all cases for these organizations, they're still providing services to rural populations, and they still need support in the rural health or in the health information technology space. And so we want to get them on board so that they can benefit from the tools that we're putting out there. In terms of reporting that's coming up, for this cycle, we're working currently, and we're going to be releasing another chronic disease report here probably within the next month, the cardiovascular disease report, which is going to be focused similar to diabetes and cancer on cardiovascular disease, its outcomes, its risk factors, screenings, and morbidity and mortality elements as well. We're also going to be working on an obstetric health report. This report's really going to be focused on deliveries, and we're going to use the severe maternal morbidity framework from CDC for this, as well as looking at maternal mortality from our death certificate information. And we're going to be looking at all of these according to whether or not the home residence of the birthing person was in an obstetric desert or outside of an obstetric desert. So we're hoping that'll be really informative and really exciting for folks. And I know there are folks on the call who've done some really good work around this space for Colorado in the past year. And then I think utilization cost reporting, we're going to do an older adult immunization report as well. We're also working on utilization and cost reporting tool that I mentioned previously. And we always leave the door open for TBD. So as providers say, hey, this would be really cool, or as a new topic comes up within the space, we want to be agile and we want to be able to react to that and develop reports based on things that people are interested in. If it's not interesting to people, we're not going to get engagement. And it's just that simple. So we like to leave the door open for that. And next slide, please. And so I just want to specifically call out, since she was not here to present on this call, but does great work for our project on our team, Demetria Flowers, who is our data insight analyst, and really runs a lot of our rural project reporting, runs our user group meetings that happen on a quarterly basis, creates our newsletter, etc., and just generally does a great job. And then all of our contact information for the folks who saw presenting here today is also available on this slide. And I think at this point, we're happy to take any questions.
Yeah, Andy, there's a couple in there, and I think they're both for you. We've got, can you talk about high level about how you linked among all the data sources? Do you have MDM?
So we have a whole team of data engineers who have built out our data network and our data scheme, and who are putting together this data on a daily basis. They also manage our master patient index tool, and so that all helps to manage all of our permissions, pull all of these different data sources together, and make sure that the right encounters are linked to the right folks so that we can present them back in the report. Is that helpful? Does that answer the question? It was pretty high level.
That's let's see. Yes, Betty says, thank you, nice job. And then Christine LaRocca asks, can you see if HTN is controlled in actual readings of systolic and diastolic BP?
Yeah, right now we can't. The closest thing that we can come to based on the data sources for this project that we have available to us, I think are going to stem from diagnosis codes that we get related to blood pressure and hypertension. The clinical data is sadly a piece that we would love to have better access to, and is on our roadmap for the future. It's just hard to know how that's going to manifest.
Perfect. Christine says, thank you. Oh, and thanks, James. I knew that question was for you. So James already got your question, Carolyn, in the chat, and you can reach out straight to James with his email address for that. Great question so far. What else do you have? If not, I talk. And there's a lot of people on this call who know me, and you know that's not a threat. I just like to talk.
I do have a question. I'll jump in, and people feel free to continue to put information in the chat. What kind of feedback are you gathering from the providers, and how often are you doing that to get input on how to change these reports? That's something that, you know, Civic struggles with too, is like, what kind of reporting is going to be valuable, and how should we change what we're doing to make it more actionable? So just curious your process on that.
Yeah, I'll start, and then maybe John and James, if you want to jump in, certainly feel free to. I know that of the reports that we've been developing recently, several of them have been requested by the Colorado Rural Health Center based on feedback that they're getting from the providers, because they're out there talking to the providers in those spaces a lot more, and they host 2 conferences with providers on an annual basis, specifically focused on critical access hospitals and rural health clinics. But also, if we're in those meeting spaces and we hear things, we definitely take that feedback back and try to make updates where we can. We do a lot of onboarding conversations in partnership with CIVHC and the providers, you know, where we'll basically do a demo for them. And that's a perfect venue to start to gather feedback. We host quarterly user group meetings, which you know, people tend to clam up a little bit in those spaces, but we do get some feedback out of those. And one of the things that we implemented to hopefully get people to provide a little bit more feedback is user polls in those meetings. And so people don't necessarily have to unmute and say something in front of everybody. They can sort of semi-anonymously put it into the user poll and submit feedback or questions in that way. So I think those have been really helpful avenues, but maybe John and James have others.
Yeah, I was just going to piggyback off that. You know, our user groups, we get a lot of feedback, as well as, you know, our conference in the fall, and then our forum, which is coming up next month. We have breakout sessions solely to go over the rural connectivity program and the CAP and what's to come, what's new. We try to get feedback from them as well during those meetings. And like Andy said, demoing is a big one too. We can get the folks right in there to the CAP, and then that seems to be where we get a lot of questions from. And of course, we take that information and pass it on and go from there. But yeah, basically what Andy said is where we get a lot of our feedback from.
Yeah, perfect. And then where I kind of come in is, obviously, you know, this is a program that is funded through, the state and through federal. And so I kind of managed this overall, but my goal here is to make sure that this is working for those in the rural community and that it's helping with sustainability and that it's helping like alleviate things that you would go into an EHR for and pay, right? And so my level of reaching out and communicating is I go to all of the things that Andy and James talked about, but I also go and visit. So for example, I'm going to Snowmass Rural Health Clinic next week. And then the following week, I'm going over to, well, not the following, but it's coming right up. I'll be at the QHN conference and I'm going to go visit Delta. And then I'm going to go visit another rural health center. And I'm going to go in Leadville and visit their health clinic. So just getting out there and helping people understand, because there is a misconception in our rural, specifically rural Colorado, that is a little bit anti-government or anti-metropolitan, and they don't want people in Denver and their business. And I fully respect that I'm from rural Florida, so I get it. And so I go out there and work with people and let them understand that this is not one of those things to be worried about. This is literally this guy right here cares and has created something that is going to help us be able to provide healthcare in rural Colorado. That is it. That's everything. And then we're getting ready to go into our next phase of the project. And so I've gotten a bunch of different providers involved in our steering committee that helps plan the next phase. I'm saying that out loud so that if there are any providers on this call, please email me and say you're interested in helping shape the future. And we'll say this project, but really it's the future of rural healthcare in the state of Colorado.
Fantastic. Thank you, all three of you. Just exciting work. I actually, prior to Civic, worked at the Rural Health Center, and that was 12 plus years ago. And back then we were just trying to get people to adopt electronic medical records, much less get it connected to HIE, much less get reporting and using it for quality improvement and all of the things. So this is exciting for me personally to see how far we've come. Sometimes healthcare improvement seems slow, but I think this has been a huge leap forward over the last 10 years or so. So kudos to all of you for the work that you're doing. Really appreciate the partnership with all three of your organizations. From the civic side as well, and appreciate your time and your knowledge and the work that you guys do. So again, this will be recorded after the fact on our events page at civic.org, and really again thank all of you, the participants out there in the world, as well as our fantastic presenters today, and I hope you all have a great day.